AMMF is really honoured this year to have co-chairs Professor Shahid Khan, who is with us on the platform now, and Professor Chiara Bracconi this year, and Chiara will be joining us a little bit later. Now, these are both hugely respected and knowledgeable specialists within the cholangiocarcinoma world, and they're going to be hosting a faculty of speakers of some 40 leading experts from across the globe. Last year, 2023, our conference theme was innovation, and we explored the many advances that were coming to the fore in research, in treatments available for the cholangiocarcinoma patient, and in our understanding of this most challenging of cancers. This year, we look to accelerate progress. The co-chairs and the AMMF team have put together an exceptional and very busy three-day program, highlighting the many innovations and improvements we're now seeing, and exploring how progress can be accelerated to ensure that these improvements reach the patient in as timely a manner as possible. The cholangiocarcinoma patient is at the heart of everything AMMF does, and they're always an integral part of our conferences. During the conference, we're going to hear from 4 of those whose lives have been touched by cholangiocarcinoma, and we're so grateful to them for their courage in sharing their inspirational stories with us. So I think before we begin, we're just about to begin our first session of the conference, this is specifically for patients and carers, but it's open to all delegates because we're going to head straight into learning about new areas that are becoming of increasing importance to everyone within the cholangiocarcinoma world. So I'd just like to wish everyone, whether you're joining us live in the UK or virtually from across the world, a most enjoyable and informative conference. And I'm now going to hand over to our co-chair, Professor Shahid Khan, who's going to open the session with his presentation giving an overview of cholangiocarcinoma, what it is, what we know, and what we need to know. Thank you, Shahid.
Thank you, Helen. My name's Shahid Khan. I'm a hepatologist, liver specialist in London. A warm welcome to everyone. It's an honour and a privilege for me to be asked to co-chair this conference that I've been coming to for many, many years. And a warm welcome particularly to the patients and their loved ones and their carers. This session is specifically or specially for you. I'm aware that we have a diverse range of people in the room with different backgrounds and some scientists and clinicians and some patients and some lay people. With that in mind, the plan for me for the next 10 minutes is to give an overview of this disease that's brought us all together and highlighting areas of the conference and particular talks and speakers that we've chosen and why we've asked them to present over the course of this conference. So what is cholangiocarcinoma? Well, it's a cancer. So when a cell just keeps dividing and dividing and the normal mechanisms that control cell growth don't work, and then one cell turns into a bunch of cells and then eventually forms a tumor, and then that can form and divide off and go to other parts of the body. So cholangiocarcinoma is a cancer that arises, and cancers can happen in any part of the body. And cholangiocarcinoma is a cancer that arises in the cells of the bile ducts. These are tubes inside the liver that carry bile. So the liver has many functions. One of the functions of the liver is to make bile, which is this green fluid that flows from the liver through this network of tubes called the bile ducts, and then eventually into the gut, where it helps digest food, where it's a route of excretion for toxins as well. And that network of bile ducts and tubes starts off very small tubes in the liver, then coalesce into bigger and bigger tubes as they exit the liver, and that network is called the biliary system. And a cholangiocarcinoma is a cancer that arises in the cells that line the biliary system. So this is where we're talking. So the liver and the bile ducts, therefore, are in the right side of the abdomen, quite high up, just under the diaphragm. And the bile ducts form the right side of the liver. The liver's, you've got one liver, but it's in two halves, two lobes. And the right side of the liver drains its bile eventually through the right hepatic duct, the left through the left hepatic duct. And if someone has a gallbladder, the bile is stored in the gallbladder, and then intermittently during the day, particularly after eating, the gallbladder contracts and pumps the bile down a big duct called the common bile duct into the duodenum, which is the first bit of the intestine. So that's the biliary system. And a cholangiocarcinoma can occur anywhere in the biliary system, from the small ducts of the liver to where the bile ducts leave the liver to outside the liver. And that gives us anatomically three different types of cholangiocarcinoma. Intrahepatic, that starts in the bile ducts inside the liver. Perihilar, just outside the liver. And the extrahepatic cholangiocarcinoma in the big bile ducts outside the liver. So they're the three anatomical variants. And this is some examples on CT. And probably around 50% of cholangiocarcinoma are thought to be the perihilar form. And the importance of these three is that not only are they different anatomically, but how patients experience symptoms differ depending on which area the cholangiocarcinoma has arrived. And now we're also increasingly, over the past few years, finding out that their pathology and how they occur is variable depending on the three, and the different types of mutations, and also different types of treatment, as we'll become aware. So cholangiocarcinoma can affect everyone. The majority of patients are over 50, but around 25% of people are under 60. The vast majority of patients, there's no family history. It's not one of these cancers that tends to have a familial inheritance. Around 20 to 30% of patients have a history of a liver condition called primary sclerosing cholangitis, which is chronic inflammation of the bile ducts. We don't know what causes it. It's a sort of autoimmune type of disease. Or they might have some other type of liver disease. But the majority of patients who get cholangiocarcinoma have no history of known liver disease, and that's called sporadic. It means it's happened without any background or pre-existing liver disease. Most patients will likely have some abnormal liver tests, blood tests, and how on the location. So if it's in the bigger bile structure, we can change it to often don't have getting a sample. The difficulty with the histology is sometimes with cholangiocarcinoma, if it's really high up in the liver, high up in the bile duct, it can be technically almost impossible to actually access that abnormality. And given that, and given how vague patient symptoms are and the lack of symptoms in early stages, all these factors mean that it can be challenging to diagnose and diagnose early. And early diagnosis is the important thing, because it's only if the patient is diagnosed relatively early that it gives them the best chance of having surgery, surgical resection, which is effectively the best and probably the only chance of cure eventually. Transplantation has not been an option in the UK for decades and in most parts of the world, although that might be changing. We will have a talk on that a bit later on. There's radiation treatments that are increasingly effective, and the mainstay of treatment, most patients will probably end up needing systemic treatment. And there's an important role for endoscopy and stenting to clear blocked bile ducts, to let bile flow, improve liver function, and therefore make patients who may not have been amenable to systemic treatment now amenable to systemic treatment. So there's a lot of specialists involved in the care of a cholangiocarcinoma patient, right from the GP to the liver specialist, to the endoscopist, to the surgeon, the pathologist, the radiologist who review the reports, the oncologists who give chemotherapy or systemic treatment, the radiation oncologists. So it's a real, what we call a sort of multidisciplinary type of disease, where you have lots of specialists, and that's reflected in the speakers that we have. So one of the concerning things about cholangiocarcinoma is many studies show rising rates of cholangiocarcinoma, particularly the intrahepatic type. We're not sure why that is. It might be that liver disease generally is increasing. There are other factors that we could talk about in the question and answer session. There have been some issues with how the different types of cholangiocarcinoma have been historically coded. And over time, we have started to develop a greater knowledge of risk factors. This is a map, a world map from a recent publication showing the epidemiology of cholangiocarcinoma. So that's different rates of cholangiocarcinoma across the world. The darker the color, the greater the rate, the mortality rate. And as you can see, the rate for intra and extrahepatic cholangiocarcinoma varies, and it doesn't just vary in each country, it varies from country to country. So globally, there is a great diversity in the rates of cholangiocarcinoma, but everywhere it seems to be going up. Globally, the highest rate is in Thailand, particularly northeast Thailand, where it's thought to be secondary to chronic liver infection with liver flukes. We don't have liver flukes in the Western world, but nonetheless, it's still rising in the Western world as well. So this just shows some recent studies showing rising rates from different countries. In each graph is a different country. The top line is rates in men. The lower line is rates in women. You can see that in both men and women are affected by this condition, and it's rising, particularly the intrahepatic variety. And this just shows intrahepatic. This line just I'm highlighting just shows the percentage change over several years in one of our recent papers from different countries around the world. I'll skip on to. Right, let me just skip through that, just for lack of time. Okay. Sorry. So what risk factors do we know? So I've mentioned PSC, which is the commonest known cause. But as I said, most people don't have PSC. PSC particularly affects younger people, under 40. And if someone has PSC, the annual risk is thought to be around about 1%, but with a lifetime risk of around 15 to 20%. In the Eastern world, as I mentioned, liver flukes. Some toxins, chemical toxins, have been linked to cholangiocarcinoma in the past. For example, thorotrust, which was banned a few decades ago. It was used in radiological as a radiological dye for many years. But then there are other factors. Most cancers tend to increase with age, same with cholangiocarcinoma, but as I said, a great deal of patients are under 60. Rising obesity rates is known to be a risk factor for liver disease and fatty liver, and that is thought to be a risk factor as well. Family history, as I said, although family history may potentially increase a person's risk, the risk is still low because it's overall a rare disease, but most cases of bile duct cancer do not appear to have a familial link. And I should say in the epidemiology that in the UK now, cholangiocarcinoma is thought to, number of new cases every year in the UK is thought to be around about 2,000 to 3,000. It's about that sort of ballpark. This is a study that we did, looked at different risk factors for the intrahepatic and extrahepatic type. So other things that we know, apart from what I've mentioned, include cysts, liver cystic disease that are usually congenital, cirrhosis for any reason, chronic gallstones, particularly if stones are stuck in the biliary tree, HBV and HCV, hepatitis B and C, alcohol, chronic alcohol excess, inflammatory bowel disease, diabetes, smoking carries a slight increased risk as well. And the relative risk does vary from where the cholangiocarcinoma arises. So, in terms of epidemiology and risk factors, there's still a lot we don't know. Where do we need to get to with our knowledge? Well, as I mentioned earlier, I didn't really have time to go into it, but the way the International Classification of Diseases, which is a system which gives a code for every single disease and every single cancer, there were some inaccuracies there for cholangiocarcinoma, which led to some inaccurate reporting, but that's hopefully been resolved. With the latest edition, so we need to make sure that we have, going forward, accurate collection of data. We need to understand the cases where we don't know what the risk factors are, why are they getting it. We need to understand more the molecular biology of cholangiocarcinoma. Dr. Evans and Prof Macias are speaking about this later in the conference. And what about the genetic drivers? And there's some of these have been looked at in novel research sponsored by the AMMF. Increasingly, there's an awareness that the gut microbiome may play a role. The gut microbiome being a collection of all the microbes, bacteria, viruses, fungi, etc., and their genes that live within our bodies. Dr. McNamara will be talking about that later. What about diagnosis? I said how diagnosis can be challenging. We need better, more accurate, more specific biomarkers that can tell us definitely if someone has cholangiocarcinoma, and earlier the better. Dr. Starling is going to be talking about liquid biopsies. Dr. Damiani recently did a PhD with me, is going to be presenting some novel work on novel biomarkers. In terms of getting an accurate diagnosis, you need experts. Do we need to have, we need to ensure that patients are seen at the appropriate centres, and Mr. Hassan Malik will be talking about that tomorrow. And we also need better pathology markers, improved pathology, and Dr. Tim Kendall, who will be following me, will be giving a talk, and Dr. Egbeniwe, also a pathologist, will be talking on Friday about better pathology markers. As I said, surgery is the best chance of cure, and a study led by the UK has showed that if you give capecitabine after surgery, it improves survival, but we need better treatments alongside or instead of surgery, including local regional treatments such as ablation, radiotherapy, transplant. We've got a talk from Mr. Takar tomorrow talking about improving outcomes from surgery. Professor Gomez tomorrow talking about how we reduce recurrence rates, because one of the challenges is that even if a patient gets to surgery, has a resection, and the whole tumour seems to have been removed, the cancer often comes back. Professor Thorburn, who's head of the transplant unit at the Royal Free Hospital in London, will be talking about establishing liver transplant for cases, and he'll be talking about that tomorrow as well. As I said, the majority of patients will need to have some form of systemic therapy. We've increasingly been using immunotherapy with some excellent results. Much of this work has been led by colleagues in the UK, Professor John Bridgewater, Professor Juan Valle, and colleagues. We're going to be talking about targeted systemic treatment to improve outcomes, focusing on the personal patient. I didn't realise all my slides were set on timer. Dr. Poliodoro is going to be talking about that. Professor Bridgewater about molecular profiling, so you can give targeted treatment and accessing patients into novel trials. How do we involve patients in research widely to make sure we're capturing people, not just people who happen to live near big centres, and Dr. Kendall will be talking about that on Friday. And we need to understand, given that immunotherapy often seems to play a role and can improve treatment responses, what's our understanding of the immune system? Dr. Amato will be talking about that on Friday. What other important areas of research and activity are there? Well, clearly, having patient advocacy, as researchers, we find out that, having patients advocates with us helps us raise awareness, raise voices, not just amongst policymakers, but amongst grant-giving bodies. It was very difficult to get funding for liver cancer research when I started because no one was interested. But, we've been flying the flag for that, and really that's been led by patients, their families, and the AMMF. Helen will be talking a little bit about that. We need to ensure that management, given how difficult cholangiocarcinoma diagnosis and management and complex it can be, recent updated guidelines have been published, and Dr. Simon Rushbrook will be talking about that on Thursday, and then we're going to have a sort of live MDT discussion tomorrow as well, where we've got some complex cases with a panel of experts giving you an indication as to how we come to management decisions. What about preventing? Prevention is better than cure. Is there a way to prevent cholangiocarcinoma? Dr. Rushbrook and I are about to embark and lead a trial to look at this, and I'll be talking about this more tomorrow. And importantly, I think it's important to learn best practice from colleagues around the world, and we're very lucky to have colleagues from Thailand and Italy, Belgium, Norway, talking about their experiences of cholangiocarcinoma. And my co-chair, Professor Bracconi, is leading ENSCA, the European Network for the Study of Cholangiocarcinoma. Professor Macias will be giving an update on that. And Professor Jayaranam Sheila will be talking about, as co-chair of Cholangiocarcinoma UK, updates on the work we've been doing in the UK. So I hope that's given you a taste of the conference to come, the important issues, and I think we've got a really exciting program, and I hope you have a really, really good conference. Thank you very much.